by PET-CT.
Thank you, Dr. Barons. Well, I'm not a radiologist, as many people in this room know, so I will not at all try to compete with that type of quality, but I think I will try and give you today an idea of what clinicians can obtain through PET added to prostate MRI, and that I think is a new topic which is very, very appealing and hot. Yes, it's the top one up here. Yeah. So this talk has been designed with my fellow colleague in radiology, Professor Jean-Paul Vallée, who has been very, very dynamic at developing prostate cancer imaging in our institution. And Professor Vallée and his colleague from nuclear medicine and myself have been able 2 years ago to get in the institution a prototype which could merge PET and MRI images, and that's where our study started, actually. Let me try and tell you how we're going to go through this. Of course, I will talk about these devices now coming up, the potential added values, then the demographics of our series, and then results, a few cases to spice things up, and a conclusion. So, here's my first slide with a black square. Never mind. Where does it come from that we should think that PET would help MRI, since MRI of the prostate is already so good, as Professor Barons showed you? Well, you know that PET is better than radionuclide scans. As a matter of fact, to disclose lymph node metastases, you see that CT and MRI have a low sensitivity of 40% with the criteria of 10 millimeters, whereas PET-CT goes up to 80%. So that's an old story. We know PET-CT. It has already helped us. So, of course, the way to go further would be, let's try it now with MRI and add the PET stuff, not to the CT, but to the MRI. And as you know, we have to choose an isotope, a marker. 18-deoxyglucose is no good for prostate cancer because glucose metabolism in prostate cancer is not very high. And it shows up that 18F choline is the isotope. So that's one thing you have to be careful when you get a patient with his MRI and PET maybe with it, that it's done with the 18F choline isotope. So there are 3 types of prototypes now out there, and maybe some of you have other ones of these prototypes. There are Siemens prototypes. We have a Philips prototype, which is called the hybrid version. These are 2 machines which are sequentially lined up, and there's a unique table that travels between those 2 machines. And that's very interesting because you can position exactly the table where you need with precision without moving the patient. And then the fusion which has to be made between the MRI image and the PET image can be precise. So that's the interest with this type of hybrid, so to say, machine. There's the insert type of machine where you have the PET, which is inside the MRI. The diameter of the tunnel is, of course, smaller, and you cannot put whole patients in, but you can put head or limbs, so it's not going to help prostates. And there are the integrated machines where you have it all in one circle, but the MRI appears to be of lesser quality. So we warmed up Philips for having the hybrid machine in our institution, and it came in February 2010. You see, these are the 2 coils, so to say, the MRI and the PET, and the table travels here, and the registration of the movements of the table are very precise, and that helps then for the fusion. Of course, it's a sequential acquisition, and it does add some time, unfortunately, and as I told you, the isotope chosen is 18 choline. Methodology is important. What we found out is that if you try and fuse images with endorectal coil, here this is a T2 image, the classic one that your radiologist shows you with an endorectal coil. If you fuse the PET imaging on that, you see that the tumor, that is the activity of the tumor here that is proven by PET, impedes on the endorectal coil. So it has not proven to be efficient to fuse images with endorectal coils, whereas if you use the phase array coil and you work on 3-dimensional images, you have a much better fusion, much more precise fusion here. This is an example of here a tumor that in 3D shows up here and with its metabolic activity on PET. So methodology, of course, is quite important. So we had 66 patients in this machine. We didn't have all that much. This is an 18-month period. First, from February to July, we had to tune up the machine. And then, of course, unfortunately, the examination costs a lot of money. Even though we have some funding, we cannot sponsor every examination. And about half of the healthcare insurances refuse to take to sponsor the examination. So this explains you why we have this rather slow recruitment. Nevertheless, we are reaching slowly the triple-digit figure. Most patients were before radical prostatectomy. We had biochemical recurrence patients, quarter of these, and then these are the smaller groups that we will talk about briefly. So first, we had to get the machine running, and what we had to do is to go and work on initial cases, checking with pathology that we were doing the right things, tuning up the machine, making it precise for the fusion. And the 17 first patients are shown in these 3 or 4 slides. We had to look at the tumors in left and right apex for every patient, 17, left and right base, mid-zone, and transitional zone. And this made altogether 34 apex, 2 left and right per patient. So we had 9 apical tumors, 9 base tumors, 14 at the mid area, and 6 in the transitional zone. So that gave us quite a nice scan of the prostate. Excuse me. And then we analyzed those activities those images that you see on MRI. The first typical image that you see on MRI, as you know, is the tumor being darker than the peripheral zone, which is whiter. And this translates into a standardized intensity in tumoral tissue, which is lower here than in normal tissue. And this, in those 17 patients, was absolutely significant. So that was a good confirmation. Then diffusion was very well explained by Professor Barents. It's the activity of the liquid in the tissue. If the tissue is dense, water moves less. And this is what happened also in our machine and our patients. Since tumoral tissue is denser, there was much less diffusion activity. So that was significant. And then we finished up with what we really were looking for. It's the PET activity. And there it's on the other way around. In tumoral tissue, as you know, the metabolic activity is meant to be higher than in normal tissue. This is measured in SUVs. And this goes to a medium of 4 here, and here a medium of 2 for normal tissue. So these were the first patients that showed us that we could go on, and the machine was tuned up correctly. Now we looked at what PET brought us supplementary to diffusion. Professor Barents showed you that diffusion was very important because it could even tell you that there was a high Gleason or an insignificant Gleason. Where what was interesting is that the area under the curve for the PET activity was a little higher than the diffusion. So that was, of course, interesting, and we were pleased with that. And this was significant. Now let's have a look at our small case series with the demographics. Of course, there is no evidence-based data yet, but it's an opening. And this is the group of patients who had an elevated PSA, who had multiple negative biopsies, and of course the urologists were fed up by doing the biopsies, and we were trying to find out the lesion with the PET MRI. So we have 5 out of those 6 who had highly suspicious lesions with SUVs that were very, well, significantly high. And the thing which was a bit of a problem is that all of these 5 had biopsies, and only 1 came back with a positive biopsy. And behind that, of course, it's full of questions. Did the 2D truss biopsy target well enough the area that should have been targeted? That is a question. We are now working with the 3-dimensional ultrasound and with what Professor Barents showed you as the alternate to his MRI-guided biopsy. It's the fusion of MRI images on 3D ultrasound. And hopefully this will help to have a higher efficiency rate on biopsies than this 20%. And one of these 6 patients was lost to follow-up. Nevertheless, 5 of the 6 patients had distinct areas with a very high SUV. So it certainly means something, and the default here in that group is, I think, the technicity of the biopsies. That's another group, cancer staging. Actually, of the 6 patients, 4 were meant to undergo curative treatment, X-ray therapy or prostatectomy. And these 4 had a median PSA of nearly 20. All had Gleason 6 or 9. And all these patients were stopped before the entrance of the room to curative therapy because they had either, both lymph node and bony metastases. So it was a useful examination because, of course, it prevented from not doing the right thing. And 2 patients had very high PSAs and were done just for a metastatic workup. One with a 66 PSA had only bone mets, no lymph nodes. And this patient was a very young patient, 48 years old, who tragically was suddenly had his PSA measured up to 300. And of course, he went into a very aggressive protocol. So we managed to do for him the PET MRI, and he had, of course, lymph nodes and mets that were positive in the bones. So as a cancer staging issue, PET MRI is interesting because it eliminates the needs to perform a bone scan and an abdominal pelvic CT scan. Both of these in this country costs nearly 900 Swiss francs. That's about $1,000. And if you add on that the price of a regular 3 Tesla MRI, at least in our country, you come up with a bill for these patients of 2,500 Swiss francs. So the cost of our PET MRI for the moment is still over that, but we can say that by adding 800 francs, you get it all in one, and that's, of course, more simple and more user-friendly, so to say, and less hassle for the people that put people in the MRIs and the CTs and do the bone scans and so forth. Biochemical recurrence. We had 17 patients. 14 of these had radical prostatectomy. This was a bit of a deception. We had only 4 patients with a site identified. Nevertheless, it was very helpful because 2 of these patients who may have received radiation therapy were spared radiation therapy. I think we went for androgen deprivation for these patients. So that's, of course, a yield of 29%, not all that satisfying. And post-XRT, there was 1 patient out of 3, PSA of 1.64 here. The average for the post-radical prostatectomy PSA was 238, not very high. And that maybe explains why we did not have so many recurrences identified. The whole group had low PSAs. This is the image of a post-radical prostatectomy recurrence. This is the MRI. You see here the bladder. You see here the lymph node areas. You don't see really much. And here comes the PET MRI, the PET added on the MRI. And you see there are 2 lymph nodes here, one here and in the iliac area, quite proximal, and one here very low in the obturator area. These are the sites of recurrence in this patient who had a 5 nanogram per milliliter PSA. Now a few cases to show you a bit these images that we get now quite often, fortunately. This patient is a young patient, 47 years old. This is maybe not such a useful case for PET MRI, but it just shows you what you get as images. These are the T2 images that you usually see. Profile, here this is very suspicious. Here on the left, on the right, sorry, this is very suspicious here. And here's the diffusion. You see it's all black here. The water doesn't move well. And here is the perfusion here, and this is highly active. This is a little area of mucosa of the rectum, which is also active, and that's the problem with the perfusion. You don't get such problems with the diffusion. And this is the detail of the diffusion, which you see here with high magnetic fields is really very active. And this patient, as you see here, had then his PET activity superimposed, and no doubt he had his cancer lesion there. That was a no-brainer. You would tell me, was it useful to do a PET MRI? Well, actually, it was useful because this patient had 3 positive lymph nodes. And he was so young that we went for aggressive treatment. He had radical prostatectomy and extensive lymph node dissection, and thanks to the PET MRI, we knew exactly in which area we had to be very careful for the nodes. So it did help for the tactics. This is the final histology with this huge tumor here, fortunately just margin negative. Now here's another case where PET MRI was more useful. Here's the usual MRI, the T2 images. This guy has a left apical biopsy which is positive, Gleason 7. So you look here in this area, not much to be seen, maybe here, it's not really sure. I would have been happy to have Professor Barnes telling me what he thinks of these images. On the profile, you don't see much. So you're there, not really knowing what's going on. You've got your left biopsy, but you don't have much roadmap, imaging roadmap. And with the diffusion here, you see that there is some activity here, definitely. So it starts to be suspicious at the left apex, confirming the biopsy, of course. And this is the final diffusion imaging here in red that you see circled. And now what do we have here? I hope my video runs. Let's see. It did run just before. Oh, no, here. Can you take this out of the way? Just this one, wait. It was just running before. We had a whole mess trying to get running. Never mind. PET MRI in this patient with the diffusion, which was suspicious, was confirmed here, and that was the focus of the tumor, which was confirmed by the histology. Now, this is perhaps the most interesting case, and that's where I think PET MRI is going to help us for tactics in prostatectomy and so forth. This guy comes up with a 7.2 PSA. He has a DRE positive on the right, and on the right, he has 2 highly significant biopsies. Nothing on the left. Bone scan negative. And what goes on? We do get those images with T2s. You know, you see here right away this dark image. This is most probably where the positive biopsies were. And it's in close contact with the capsule, so it may be a T3. But on the right, on the left, I mean, sorry, where the biopsies are negative, also nothing to be seen. Here we go now with the diffusion. The diffusion shows you here that the lesion on the right is confirmed. The biopsies are positive. This is no interesting input. But you see also here that on the left, where the biopsies are negative, diffusion shows you nothing, unfortunately. Now, what does MRI add to that? These are the fusion images. This is the right lesion that we know is there. Diffusion was positive. Here comes another lesion here at the left apex with a SUV of 3.5, and this was confirmed at pathology. You see here on pathology that we did an extrafacial prostatectomy on this side here, wide margin of area. We were happy to do that because here this was on the capsule. And here on the left, here is the lesion at the apex. And this lesion was not picked up by the biopsies, was not picked up by diffusion, was not picked up by T2 images. So that's, I think, the case of images that will help us with PET MRI in the future. Unfortunately, on the 31 cases that we have done, I cannot give you complete figures right now. We're still working on this, looking at the data, comparing with pathology, but this should come up soon in an abstract in the coming meeting. Now, we also looked at what MRI by itself brought. We were not going to just sit there on PET images, and we wanted to show Professor Barents, unfortunately he's gone, what we could do with MRI. And what was interesting was the following. We tried to assess whether MRI had changed our tactics as compared to not disposing of MRI when you have to make a decision for prostatectomy strategy. And what comes up is the following. We had 12 CT1Cs, and MRI modified tactics in 9 of our patients. 6 of them were under stage at CT1C. There were more than that on the MRI. And CT2A tumors, 13 of them, 8 patients had their tactics of prostatectomy modified as concerned with nerve sparing and so forth because of PET MRI. So this means that 17 of these 25 patients, thanks to the interesting 3 Tesla endorectal PET MRI that we had, in more than 2/3 of patients, it changed our surgical tactics. For CT2B and for CT2C, we had no change, and there was one CT3A tumor that was understage. So basically, I think what MRI brings you is in those low stages, it can really help you and get closer to the prostate capsule and tell you what is invaded. Take-home message, I would say, is the following. Tumor detection. You need, because it's a good help to have PET MRI. As you saw, we had 5 out of 6 patients who had high metabolic lesions. You need then a high-precision target biopsy. And the question is this, or eventually guide your biopsy directly with MRI. For the overall workup, it's the all-in-one concept, but the price increase is plus 30%. Before radical prostatectomy, the foci detected by MRI may impact on surgical tactics, and the 3 Tesla, this is PET, I'm sorry, and this is the question that comes up, and we have to give you the numbers, we don't have them entirely, and as I just showed you, the 3 Tesla MRI definitely modified our surgical tactics. And for biochemical recurrence, for the moment, the site identification was not very high, and of course, sensitivity has to be increased. I have to thank one of my residents who's been working very hard on those data, and I thank you also for your attention.
Yeah, very interesting. I just had a question about these who have PSA relapse after radical prostatectomy, and you have quite low, only 29% or something.
Yes, it's low.
I've seen some new publications where they have better detection rates. Yeah. At what PSA level do you think it gets any meaning to do PET-CT? Is it PSA 1, or have you to wait until 2, or have you any idea about how high PSA should be?
We have two small numbers. All I can tell you is one of the patients that was detected had a PSA of 0.7, which was very low. We were very fortunate to detect it. And the extreme other side of the range was 6. And we ended up with a 2.3 average for those patients detected. I know that in other studies, with a lower threshold, they had a higher yield. So, I think it's a question of tuning up the machine, having the right isotope in good shape, and many things like that that make the difference. But to give a threshold is difficult. Maybe somebody else in the room wants to give a position on that.
Just a short comment. As I was told, I shouldn't ask a question because we're running out of time. One criticism I have to the study, for example, if you see in patients with suspicious PSA and you see some focus in your PET MRI and you stick a needle in and there's no cancer, you say the biopsy quality was low. Maybe it's the specificity of the MRI that is low. I think that's a thing you should discuss as well. And the other thing, changing your management during radical prostatectomy by MRI doesn't mean you change it, doesn't mean that you make it better. And that's something else you should consider. For example, frozen section is something that you can tailor it. And this is something you should discuss as well, I think.
Now, we will be, to answer to the second question, we will be looking at, I only showed you the 2 first stages of our study. And of course, the 3rd step is looking at pathology. And if those changes, those maybe risks that we took according to capsular penetration or not, were well taken, absolutely. And regarding the sensitivity with prostatitis, of course, this should be questioned. But we had one patient who had a whole metabolic activity of his prostate, and that was clearly a prostatitis, you see. But when you get a focus, it could be a prostatitis focus, but nevertheless, we have to maybe think that it is prostatitis. I agree with you.
One short question. to detect prostate cancer in transition zone is sometimes difficult, also with MRI. Does PET MRI help to detect prostate cancer in transition zone?
Again, Christian, we have to look specifically at those cancers that I cannot give you the answer. We're working on that. Absolutely, the PET activity is anyway high in the normal tissue of the transition zone, and that's a problem. But as what I can remember for working on the data, the cancers that were detected had an even higher SUV activity. So if you tailor the SUV activity according to the zone you're looking at, meaning peripheral zone, the SUV activity should not be so high to be showing cancer, but for the transition zone, it's much higher. Then you could probably get good information for the transition zone.
What happens with your PET quality after radiation therapy? On the prostate, the first question.
Wait.
After radiation therapy of the prostate, do you see differences in the quality of imaging with the MRI, PET MRI? That's the first question.
Yeah.
And what is, or do you see a difference in quality or detection rate when you compare PET CT with PET MRI concerning the lymph nodes?
Yeah, we haven't compared PET CT and PET MRI at this time. And regarding the effect of radiation on the tissues, we had 3 patients that had radiation therapy and then that were screened for biochemical recurrence with the PET MRI. We will have to look into that. I can't answer you either. Yeah. Okay. Oh. So, yes, we are now having...